My name is Matthew. I'm 54 years old. I was first diagnosed as a child. I had childhood asthma, and then I outgrew it, but then it came back again approximately around 2009.
As a New York City police officer, were there any special exposures that you had over the years?
Yes, I did. From 9/11, the tragedy of 9/11, I was down there the first day, and then for the next month and a half, I was exposed to all the dust, the debris, the asbestos, and I was told that more than likely was one of the triggers that triggered my asthma to come back.
How do you define asthma severity? And it doesn't matter if it's ATS, ERS, or anybody else definition. We're really learning more and more about asthma in response to therapy.
What is it? What does it do? Where does it come from? Could you explain a little bit about the mechanism?
So IL-5 is important for the eosinophil activity, eosinophil life, how it functions. And if you can block that, either attaching to the eosinophil or knocking it down its level, free floating level, then the eosinophil will decrease in number, decrease in the secretion of the toxic products they have. So it is a very important Th2 or type 2 cytokine. Blood work, CBC, and differential, that will let you know the eosinophils and how high the total eosinophil count is, which is also significantly important.
We do bronchodilator reversibility the way the ACRN network does, which is a maximum test, starting with 4 puffs, adding another 2, and if they improve at that level, going up to 8 puffs. And we've added to that an additional 4 puffs of an anticholinergic ipratropium. And we often see further bronchodilation. Part of that reason is because knowing someone's baseline lung function, withholding drugs, not just a random, and their maximum, helps us characterize them within some non-biased clusters that we've published extensively on. But it may be, if what we're dealing with in severe asthma is a complex phenotype where you have multiple biologic characteristics involved in the phenotype, we may need more than just an IgE level to predict response.
We need to explore more. How can we really refine? Maybe other biomarkers can do so. Which patients will, which patients won't. So I think this is exciting.
The latest drug to be published are 2 papers on benralizumab, which is an IL-5 receptor. Very similar populations, average of between 2 and 3 exacerbations in the past year, between 40 and 50% reduction in exacerbations with the use of this drug, modest improvements in lung function of about 150 mils over placebo, and some evidence of potential improvement in symptoms. This drug isn't yet registered. I think it's on its way to being registered, so we'll have 3 choices in this area for eosinophilic Th2 asthma.
And do you have any strategies, anything that you could offer to get patients to adhere to their medication?
I firmly believe, which is difficult in a community practice, let's say that you're really time limited, but if you do take the time to explain to the patient what asthma really is, I mean, you have to start with the basics, it doesn't take that long, and why drug X, Y, or Z are being used, and bring them into the decision-making process.